Hi guys, how are you? Let's do a little bit of neurology. Pull up the material. So, neurology that you need to know is kind of straightforward. They're not expecting you to know too much. But remember, what I give you is not just for the course, right? It's something that you want to keep with you throughout your education, at least. And obviously, if you're going to go into a specific specialty, you're going to build up on this. So, let's do the basics of pathology that you absolutely need to know. Listen in when I do this during the class. These are things that you absolutely need to focus on. Remember the Christmas tree? This is your Christmas tree. The rest are the little, toys that you hang on. So you know that neuron A, let's say, call it neuron A, and neuron B, two neurons that are in tandem or right next to each other, communicate with each other with things called neurotransmitters. So something that they transmit from neuron A to neuron B or neuron B to neuron A. It's a way they communicate. Okay, so neurotransmitters are chemicals that neurons talk with. Using those chemicals, neurons can talk to each other. Okay, so the most common neurotransmitter used, you probably learned that in your anatomy. And once again, go back and listen to your neuroanatomy to kind of get a big picture. Okay, so let's say we're talking about another neurotransmitters, neurotransmitter, and there are many. There are many. Let me name one. Let me name one amino acid. Amino acid. So it has an amino and an acid group. Amino acid. That's the fundamental part that builds up the proteins, right? So you need to connect. Where do proteins come into play? Connect. Go to your gastrointestinal system knowledge. Connect those things in there, okay? So glutamic acid, another name glutamate, is a way that neurons stimulate each other. But what happens if there is too much of that glutamate, glutamic acid or glutamate? You can use them interchangeably. So what if that neuronal stimulation by glutamate is at toxic levels? That means, you know this, neuron A, for example, is producing massive amounts of glutamate. Well, what happens is that, and we've seen that in our experiments, is that too much calcium is produced, okay? And you know calcium is in the bones. I was telling you in the endocrinology lectures that calcium is stored in bones, right? Calcium and phosphate together is what makes those bones actually strong, right? But in this case, if there is too much glutamate at toxic levels, too much calcium is going to go into the cell, okay? So too much glutamate, then too much calcium enters the cell. And what you studied in your week 1, if there is too much calcium, it kills neurons by apoptosis, by activating the death enzyme, cell-mediated cell death, self-suicide, right? Okay, suicide. So once again, neuron A activates, releases too much of glutamic acid, too much calcium enters into the second cell. It commits suicide by, the process is called apoptosis. Why is that so? It's because the enzymes that cause death are activated. Okay, apoptosis happens. Now, something that is less severe is something that probably all of you have seen because it's found in about 1% of the population. I personally have seen it 2 times in 2 of my classmates. Okay, and literally happened during the gym class. Both of them fell down, and when we see that, we know it's either epilepsy or seizures. Okay, so epilepsy is a neurological disorders is a neurological disorder that may be due to a problem with these, with the channels on the membrane of the cell, those proteins that allow ions such as calcium, sodium, potassium, magnesium, and so on to go in and out of the cell. So the membrane is the boundary of the cell, right? So epilepsy is a neurological disorder that is due to a malfunction of these ion channels. What is an ion? It's a charged molecule. For example, calcium that is charged, it has 2+. You had it all in chemistry, right? That's an ion. Sodium is always charged, Na, you know the table salt, NaCl, right? So sodium molecule is Na+, chloride is a Cl minus ion, right? So epilepsy is a neurological disorder that may be due to a malfunction, so the problem with these channels, okay? So when do we say we see this, first of all, how do we see this electrical activity? We actually see it on a using electroencephalogram, a reading of the electric currents of the brain. Electroencephalogram, so we see some kind of an electric activity, okay? So when this activity is abnormal, we say a patient has seizures, okay? So, so obviously when it happens only once, we call it a seizure, and when it happens repeatedly, we may come to a conclusion that the patient has epilepsy, all right? So there are different kinds of seizures, and you hear about them all the time: generalized, partial, tonic, atonic, tonic-clonic, and so on, okay? How about we just discuss one of them? Okay, let's talk about partial seizure. Partial seizure has another name. It's called focal seizure, okay? And we define it, we call it focal. Focal means what? What do we say? When we think focal, how are we going to remember it? Focal means it has a one focus, just like the focus on your camera. Well, recently everybody uses autofocus, but you know, for those of you that are really interested in like high-end cameras, you can actually manually focus, right? That means you see only something and not things outside. So focal seizure is a seizure of one place in the brain and not others. So this electrical activity that we see on electroencephalogram that is abnormal is seen in only one place of a brain and not elsewhere, okay? And usually we talk about only half of the brain, half of the whole brain that looks like a ball, so half hemisphere, all right? So when this seizure is focal, we call it partial. When it's partial, we call it focal. It's used interchangeably, limited to a certain area of the brain, usually half of the brain. Okay, that's pretty much all you need to focus on when I'm teaching seizures and epilepsy. We will be talking about a disease, and I'll show you how to recognize that patient when I'm teaching. But there is a disease that you've all heard about. It's called Parkinson's disease. Parkinson's disease is due to a problem with another neurotransmitter. Just now, we talked about a neurotransmitter called glutamic acid, another name glutamate. What did I tell you? When glutamate goes and there are toxic levels of glutamate, right, around, too much calcium goes into the cells, killing them, right? But in this case, we have a progressive loss, that means decrease, of the neurotransmitter called dopamine. And you've all heard about dopamine because dopamine is an important neurotransmitter also in your endocrinology. Dopamine is important in stimulation, decreasing stimulation of prolactin, which increases milk production in mothers. Another name for dopamine is prolactin inhibiting hormone or prolactin inhibiting factor, PIF. Okay, so wipe your slate clean again. Let's talk about Parkinson's disease. Parkinson's disease patients have a progressive, that means keeps on going and getting worse and worse, loss of the neurotransmitter called dopamine. And this happens, we don't know why exactly. There are different, there are different developments showing the direction of why it's happening, but there is a loss of neurons in one particular area of the brain called midbrain, and more specifically in a part of the brain called substantia nigra. We call, so it's a part of the, it's just above what you call the pons, okay? So midbrain, substantia nigra, okay? Midbrain, substantia nigra. So if you lose neurons in substantia nigra, you have, if you lose them slowly, you have decrease in production of dopamine. Why is that so? Obviously, because they make dopamine, okay? And so I'll show you what happens to those patients. Those patients start walking in a different way. They have tremor, rigidity, akinesia, postural instability, and so on, okay? Shuffling gait. And I'll show you and I'll go over it so that you can recognize it, okay? So let's go over two more diseases that have a little bit of a different etiology that is in a way very similar. Both of these diseases are very closely related in terms of how patients get those individual diseases, although one of them happens in the central nervous system, that means the brain and the spinal cord, and the other one in the peripheral nervous system, okay? But what happens is in both of these diseases, there is a damage to myelin. And as you know from your anatomy, you learned that myelin is that insulation, that wrapping, that fatty wrapping around the axon, and axon is the longest projection from the cell body. Okay, so neurons have a cell body, and neurons have that one very, very long projection. So all others are very short projections comparatively. One of them is very long, that's called axon. That axon takes the information away from the nerve body, right? The dendrites, they receive the information. Axon takes that information away, where to? To the muscle or to the other cell and so on, right? So because we need that information to travel far, travel very far, we need a proper wrapping. Why? Insulation, to prevent current from leaking. So it's kind of related to ion channels as well, okay? But what happens is there is simply a damage to that wrapping, damage to that axonal myelin sheath, okay? Now let's review. In the central nervous system, which is the brain and the spinal cord, what is that axon wrapping made up of? It's the cells called the glia cells that are called oligodendrocytes. So the wrapping is made by oligodendrocytes. In the peripheral nervous system, wrapping is made by the cells called Schwann cell, SCHWANN, okay? Schwann cells. Okay, now listen in once again. CNS, oligodendrocyte, wrapping. Peripheral nervous system, that means your arms, your legs, Schwann cells. Okay, so if you damage myelin, the protective sheath around the CNS axons, you get a disease called multiple sclerosis, and you've all heard about that disease. Multiple sclerosis is due to a damage of myelin in the CNS. Don't forget that CNS wrapping is done by oligodendrocytes. Part 2, syndrome called Guillain-Barré syndrome. That is usually seen after infections, and you will hear this from me for gastrointestinal infections. Someone who had a diarrhea, someone who had maybe it's a young who was recently diagnosed with Campylobacter jejuni, Campylobacter jejuni infection. Jejuni means what? It's not in the duodenum, but it's in the jejunum. It's not in the ileum, somewhere in the small bowel. Its name, Campylobacter jejuni, is a bug that causes diarrhea. So infections may cause Guillain-Barré syndrome, and this is due to a rapid demyelination of the peripheral, that means arms, legs, periphery, outside of the central nervous system, not the brain, not the spinal cord, peripheral nerve axons, and this is usually associated very closely with inflammation, okay? So one important thing is that because patients' peripheral nerves are damaged, they can no longer, initially they start complaining about, tingling sensation in their legs, and it kind of goes up. You've got to keep them on the ventilator because the damage goes upward and eventually reaches their diaphragm. And you know what happens if a diaphragm is affected, right? Diaphragm is a skeletal muscle. What does a skeletal muscle mean? Skeletal muscle is controlled by what? It's controlled by nerves. So you basically tell, move, don't move, move, don't move. What if those nerves are damaged, too damaged to talk to your muscles? Well, the muscles will just relax, and so you will not be able to breathe. So a patient will require a ventilation. Okay, so multiple sclerosis, damage to axons wrapped with oligodendrocytes in the CNS, central nervous system, so the brain and the spinal cord, damage to myelin, and Guillain-Barré syndrome is seen after the infections and is due to demyelination of the peripheral nerve axons, damage to Schwann cells. Okay, now let's talk the next topic. Next topic is stroke related. Okay, let's talk about different definitions. Increasing severity. So there is a word called paresis. There's a word called paralysis. And you've all heard that term, paralysis. I'm paralyzed. I couldn't move. I was paralyzed. I was so scared, right? So just remember, paralyzed means you can't move. And everybody knows that. Paresis is a weaker forms of I was paralyzed. Okay, so paresis comes from the word relaxed. So it's kind of a weaker form of paralyzed. Okay, so where is this word used? It's used as a part of the word hemiparesis, but we don't say really hemiparalyzed. It's not really used. We say word hemiplegia. Okay, hemiplegia is literally translated as half stroke. Okay, hemiparesis is less than hemiplegia, just as paresis is less than paralyzed, less severe. Okay, so how can a patient get stroke? Well, there are multiple ways of how it can happen, and you've studied in your books that maybe the patient had atherosclerosis of the carotid artery, right, in the neck. Atherosclerosis does what? It builds up atheromatous, so porridge-like substance in the wall of the artery, and at some point, some of it that plaque that is built up might rupture, just travel along with blood, and it's a little piece that's traveling in the arteries. And what if it encounters a an outlet that is smaller. So if this is the size of that little plaque that God displaced, what if it moves and now it's found a smaller pathway, the narrowing of the artery? What is it going to do? Nothing. It's just going to block. Okay. So is that a big deal? You obviously understand, right? Blood can flow no longer because we have an occlusion here. We have a closed door. So the blood doesn't flow anymore. What's the term for that? Week 1, week 2, week 3, ischemia. So we'll have a stroke due to ischemia. What do you think we call it? If not ischemic stroke. Okay, ischemic stroke. So arterial fibrillation is another reason why it may happen. And I talked about it in your heart curriculum. Let's do it again. Heart is a pump. It's supposed to, so blood comes into the heart. What does it do? Squeeze it out. Comes into the heart, squeeze it out. In atrial fibrillation, heart is not squeezing things out. It's beating like so. Okay, so it never really compresses anything. So you know this musculature around the heart, it's kind of like faking that is beating, just teasing you like so. Okay, so blood comes here, and what does the heart do? Beats around it. And what do you know about blood? You know that if there is lack of motion of blood, and we call it stasis, if the blood is diseased, it clots too fast. We call it hypercoagulability. Coagulation is too fast. Stasis, hypercoagulability, or damage to the blood vessel, endothelial injury. A thrombus may form, and you know the next step. Thrombus flies first to the lungs, pulmonary embolism, right? But what if, so heart atrial fibrillation, thrombus forms, stasis, hypercoagulability, or endothelial injury. In this case, it's just stasis. Fine. Not so fine, actually, right? So thrombus forms. What happens next? At some point, something happens to this heart, or it really doesn't. This clot just feels like, you know what? I'm going to become an embolus. And it flies away. And it becomes a pulmonary embolus because it flies toward the lung, because it's atrial fibrillation, right? Usually, for example, in the right atrium, okay? Okay, what if it's in the left atrium? Okay, atrial fibrillation, left atrium. What's the next step? Mitral on the left valve. What's the next step? Aortic. The left ventricle. What's the next step? Aortic valve. What's the next step? Aorta. One of the exits before that aorta completes the loop to go down to your legs is the carotid artery going to your brain. Can thrombus just decide to go upwards? Well, thrombus doesn't have any preference. It's like, fine, I'll go there. I'll go wherever. I don't care. So if it's on the left side, atrial fibrillation clot may go to the brain and cause a stroke. Either hemiparesis, better than hemiplegia, worse, half stroke. Okay, so atrial fibrillation, carotid stenosis, and any other kind of atherosclerosis in the blood vessels, cerebral arteriosclerosis, okay? They may all block off the blood vessels and cause ischemic stroke. And don't forget that those 3 points, the stasis, hypercoagulability, and endothelial injury, are your Virchow's triad. You need it. They'll be talking about it in your future. All right, now, so there is an interesting, so worst case scenario, that thrombus goes to, the thrombus or the plaque, flies, blocks off the blood vessel, and the whole brain does not get any blood. And it's called anoxic, no oxygen, like anemia, no blood, hemia. Anoxic means no oxygen, right? So anoxic encephalopathy, the disease of the encephalon of the brain. Anoxic encephalopathy, no brain for the, no oxygen for the whole brain, right? The term that we use for anoxic encephalopathy is actually hypoxic ischemic brain injury. Hypoxic ischemic, one word with a hyphen, brain injury. Okay, but anoxic encephalopathy, that global anoxia, very rare, very uncommon, maybe due to a little kid falling through ice in a pond, or drowning, or some rare carbon monoxide poisoning and so on, where global brain supply of oxygen is decreased, right? But it's kind of rare. But what is common is cessation, decrease of blood flow to a part of the brain tissue, right? And one thing that's common to all types of stroke is decrease in consciousness. Decrease in consciousness because remember, this brain works together. So let's say someone is a, I don't know, football player, right? And someone got a severe damage to the thigh, okay? Is it just the thigh that's going to be affected? Is the person will otherwise is going to be otherwise totally okay? No, other parts of the leg may not be okay. The pelvis will feel like kind of shut. Wow, that was bad. And you will not be feeling well in general, right? Because a damage is a damage. Similarly, any hypoxic ischemic brain injury is associated with decrease in consciousness. Okay, please remember that. And that's the worst case scenario. Excuse me. My delicious green tea that keeps me going. All right. If this doesn't happen, there may be something else happening, and that's called TIA. We call it TIA for transient, means comes and goes. Transient, it came and it left. Transient ischemic attacks. Ischemia, decrease in blood flow. So transient ischemic attack, something. So this ischemia attacked the brain only for a short time. It's in the name. It's in the name, guys. Always pay attention to the names. Names, and that's why you want to memorize those Greek and Latin terms. They're going to make it or break it later on, because you don't want to be relearning things or just like memorizing them without understanding. It makes life much harder. Okay, so transient ischemic attack is a small hypoxic ischemic event that is temporary, okay, and resolves on its own without tissue death. What is an example? A patient will come to you and say that he saw, it's usually he, right, myocardial infarction. Who is it more common in, the ladies or the guys? Unfortunately, it's the guys, right? And ladies are like, why unfortunately, right? No, it's unfortunately the guys, and obviously we care about everybody. Every patient's life matters. And transient ischemic attack is a short damage that the patient will be saying, like, a curtain came over, let's say, the right eye. Remember, it's always one side or the other. Global stroke is very rare. You would not be talking to that patient, okay? Possible? Yes, very unlikely, okay? It's either the right side or the left side, okay? So a patient will say he could not see, it's as if a curtain came over, let's say the right eye, let's say the left eye, was there for a few minutes, and then the curtain just left, and then he or she could see again. Okay, we call that transient ischemic attack. Don't forget, by definition, It's less than 24 hours. It's just a definition. Obviously, you know, the longer you wait, the less the chances of tissue not dying are, right? Because neurons start dying after 3 minutes, you know, 3 minutes. Very, very hungry for energy, food, and oxygen. Okay, so last point that I want to make is that there is a thing called rupture of a cerebral, that means a brain, aneurysm. You know what an aneurysm is. It's a dilated blood vessel. Okay, cerebral aneurysm means it's a blood vessel that is dilated, that is in the brain. And you know from your studies, it's usually a buried aneurysm somewhere in the circle of Willis, right? That part of the brain that receives the blood from, you know, your circulation let's not go into details, from various kinds of circulations, okay? Both the carotid and vertebral arteries, they come together, form that kind of a circle in there, okay? So one of those arteries, let's say it has a little bubble. We call it a baryaneurysm. Let's say it blows up, and it will. Any aneurysm, by definition, will blow up. It's just a matter of time. We don't know when. No one knows when. Okay, no one can predict it. The larger it is, the more likely it is to blow up, to burst. Okay, so rupture of cerebral aneurysm obviously lets all that blood out, and we call it subarachnoid hemorrhage. You all understand why it's a hemorrhage, because it's a rajain, is a bleeding. Hemo means blood. Hemorrhage, bleeding of blood. Fine. Why is it called subarachnoid? Go back and watch my anatomy videos. Early on, I say what? There is a dura, there is a pia. Dura is stuck to the calvarium, and pia is stuck to the brain, and in between, there is arachnoidea that is kind of touching the dura, but it also has those spider-like projections. And because of these spider-like projections, we call it arachnoidea. Well, in between those spider-like projections, we have a few things going. We have blood vessels running through arteries and so on, right? But also the cerebrospinal fluid. So if an artery or an aneurysm would burst, obviously the bleeding is going to shoot right in here, right? Chances of surviving a subarachnoid hemorrhage are very slim. 1 in 50 patients, 50% of the patients die even if they reach the hospital on time. Very bad, very unlikely to recover. And just remember, because it's a bleeding, the stroke is called hemorrhage. Correct. You as ongoing clinicians must also remember, and I'll stress it in class, that within 7 days, these patients will have an ischemic stroke, and that's because the blood vessels, all that blood that's around, that's leaked out, that now coats those free blood vessels in that subarachnoid space, will cause them to narrow, okay? And that is going to cause ischemic stroke. And that's why you give medications, and the medication is called nimodipine. Anyone going to work in emergency rooms or in neurosurgery will be very familiar with this medication. All right, that concludes neuropathology. Let me stop the recording.